Good evening, everybody. In today's lecture, we'll learn about jaundice. Now, how do we define jaundice? So, first of all, there are four important terminologies. First is hyperbilirubin, hyperbilirubinemia. Second is jaundice. Third is icterus. And fourth is cholestasis. These four terminologies should be differentiated from each other. So, first of all, what do we mean by hyperbilirubinemia? So, bilirubin is produced by the breakdown of the RBC and the other heme proteins. Okay? Bilirubin is a very toxic. It is produced by our body on a daily basis. Our body per day produces a bilirubin about 0.2 to 0.3 grams per day. This bilirubin is very toxic and should be pushed out of the body. The normal range of the bilirubin varies from 0.2 to 1.2 mg per dl. If the bilirubin rise beyond this level, it is known as hyperbilirubinemia. For example, this is the normal range of the bilirubin to 1.2 mg per dl. This is the normal range of the bilirubin. Now, if the bilirubin goes beyond this level, then the patient may not have the yellow discoloration of the skin, sclera, interstitial fluid, and mucous membrane. The patient will not have the yellow discoloration of the skin, sclera, mucous membrane, and interstitial fluid. When it rises beyond 2.5 mg per dl, if the bilirubin goes beyond 2.5 mg per dl, the bilirubin should be present in significant amount to produce the yellow discoloration. So if it raises to 2.5 mg per dl or beyond, it produces the yellow discolorations of the skin, sclera, mucous membrane, and the interstitial fluid. So this condition is known as jaundice. Not every hyperbilirubinemia is a jaundice. It should be present in a significant amount and produce yellow discoloration. If it is present in a mild amount, it won't produce the yellow discoloration of skin and mucous membrane. But if it raises beyond 2.5, it will produce the discolorations of the body tissues and it will produce jaundice. Now, what do I mean by icterus? Icterus means the yellow discoloration of sclera. Okay. So, due to hyperbilirubinemia. Icterus is a yellow discoloration of the sclera due to hyperbilirubinemia. Now the sclera becomes very easily becomes the first clinical presentation to be appeared in a patient having jaundice. Why? Because the sclera is white in color. First of all, the sclera is white in color, so it becomes very appreciable in presenting the yellow discoloration. Second, that the scleral connective tissue love to bind with or are more prone to bind with bilirubin. So this icterus develops very easily in a patient having jaundice as compared to the other body tissue. Then we have the cholestasis. Now what do I mean by cholestasis? Cholestasis is defined as impaired bile outflow. Impaired bile outflow. Now, bile is composed of three components. Okay, first is the first component, which is also, of course there are many other components, but the three main components we have is bilirubin, then we have the bile salts and acid, and third we have cholesterol. So what happens that if the bile outflow is obstructed, then this bile gets spilled into the blood, and the patient will have the elevated level of bilirubin, elevated level of the bile salts and acid, and also the elevated level of a cholesterol. So if the patient have all these three conditions, it is said to be cholestasis. Okay. If bilirubin alone is elevated, it is known as hyperbilirubinemia. And if these three conditions, if these three components are elevated together, then it is known as cholestasis. Okay. So now we'll learn about the normal physiology of a bilirubin, how the bilirubin is produced in our body. So we'll see that first. Now, as discussed, that the bilirubin is produced by the breakdown of RBC. Bilirubin is produced by the breakdown of RBC and other heme proteins and normally the RBC are constantly being produced by our bone marrow, and after 120 days these RBC becomes old, and these RBC reduces its plasticity. So what happens that this RBC, when it's reduces its plasticity, when they become old, they get stuck in the narrow circulatory points, such as the cords of Bilroth, which are present in the spleen, and also they get stuck in the other narrow circulatory points of the liver and bone marrow. Okay. Compared to the RBC, which are young, now the younger RBC have a considerable plasticity, so they can easily twist and turn, and they can escape the narrow circulatory points. But these RBC have the reduced plasticity. So what happens? They get stuck in the cords of the Bilroth, which is present in spleen, and also additionally they get stuck in their liver, tiny points of the circulations in the liver and bone marrow. And one thing to say that the RBC have certain surface protein, and the RBC do not have nucleus. So when the RBC gets old, this surface proteins get denatured. Okay, this surface protein gets denatured, and when this protein gets denatured, as the RBC does not have the nucleus, they cannot resynthesize them. So they become old, and they lose their plasticity. So they stuck in the narrow circulatory points. So as soon as they get stuck in the narrow circulatory points, the macrophages gets activated. When this macrophages will get activated, it will phagocytize. It will phagocytize the RBC, or it will engulf, or it will eat the RBC. So it becomes clear that the RBC is broken down inside the macrophages. Okay, inside the macrophages. Now, this RBC is composed of two components. RBC is composed of two components. So suppose first we'll draw a spleen here. Okay, we'll draw a spleen here. Okay, this is the spleen. Say inside it is a big macrophage. This macrophage has engulfed an RBC. Okay, this is an RBC. So the RBC is composed of cell membrane and cytoplasm, which is rich in hemoglobin, which contains hemoglobin. Okay. So this RBC, when it breaks down, this process is occurring here. This RBC, when it breaks down in three components. First, we have the hemoglobin, then we have the cytosolic proteins and enzymes, and we have membrane. So this membrane is broken down into proteins and lipid. This lipid is broken down into free fatty acid, and the protein is broken down into the amino acid. Okay, this free fatty acid and amino acid is consumed by the macrophage itself for its own purposes. Okay, this is consumed by the macrophage for its own purposes. Then we come to where then we are left with two components, that is hemoglobin and the cytosolic protein and enzyme. So this again gets broken down into the amino acids. Okay, then we are left with the hemoglobin. Now the structure of the hemoglobin is made up of the pyrrole ring. Okay, say this is the pyrrole ring. Okay, pyrrole ring. When we fuse four pyrrole ring together, it will form a structure. Okay, it will form a special structure which is called protophyrin. This structure is called protophyrin. Okay, like imagine this is a flower. Its petals are the protophyrin. Okay, its petals are the protophyrin, and when this center portion of the protophyrin is loaded with the iron, when this central part is loaded with the iron, it will become heme. It will become heme. Okay, and when we fuse this heme with a globin chain, it will become hemoglobin. Now here, one hemoglobin molecule is fused with one globin chain, so it is known as a hemoglobin monomer. Hemoglobin monomer. But normally, hemoglobin molecule is a tetramer. Hemoglobin molecule is a tetramer. Like for example, this is the protophyrin. This is the protophyrin. Tetramer means 4. Okay, this is the protophyrin. It is loaded. When it is loaded with the iron, it will become heme. Okay, when it is loaded with the iron, it will become heme. Two heme groups are joined with alpha globin chain. Is joined with alpha globin chain. This is the beta globin chain, and this is the beta. So this is one molecule of hemoglobin. So now, inside this macrophage, this hemoglobin, with the help of enzyme, is broken down, and it will bring this iron out of the protophyrin. Now, this iron is very dangerous. It will interact with the cellular protein and it will damage. So, there are special proteins which are always present in the cell that will handle this iron. These are called apoprotein. This apoprotein will fuse with the iron and will form ferritin. Okay. This ferritin, when many ferritin comes together, what it will form, it will form hemosiderin. This when many ferritin will fuse together, it will form the polymer of the ferritin and it is known as hemosiderin. Hemosiderin. This is called hemosiderin. And the left part is the broken protofirin, which is called biliverdin. Okay. If it's in cyclic form, then it is called protofirin. But when it is in broken form, this hemoglobin will be broken down into the biliverdin and iron. So the enzyme responsible for the conversion of a heme into biliverdin is known as heme oxygenase. This enzyme is responsible for the conversion of heme to biliverdin. This biliverdin will be converted to bilirubin with the help of enzyme which is known as bilirubin reductase. It is getting reduced. Okay. So this process of bilirubin formation occurs inside the macrophage, right? Now, once the bilirubin formed in a macrophage will come out, so we'll draw here the structure. That is, this is the spleen. This is the capillaries. This is the capillaries. Certain capillaries. This is the liver. Okay. In the liver, we have hepatocytes. This is the gallbladder. This is the stomach. Okay. Okay. So this is the spleen. In the spleen, we have the macrophage, into which the RBC is broken down into the bilirubin. And this bilirubin, after its formation, as we saw that after its formation, it will release from here. Okay. This bilirubin. Now, as discussed, this bilirubin is very, very toxic. This bilirubin is very toxic, so it should be trapped. It should be trapped within the circulatory system. It should not diffuse, as it is a very small molecular size. It should not diffuse back into the tissues, otherwise it may produce toxic effects. So there are special proteins which are prepared inside the liver. These proteins comes in a plasma, so these are known as plasma protein, and it will bind with the bilirubin here. And it will bind with the bilirubin here. Now this, after binding with the protein, it will become larger in size. This molecule becomes larger in size. So can it diffuse back? No. So it won't diffuse back. Also, it is a membrane bound bilirubin, so it won't be able to get filtered into the nephrons. So this form of bilirubin is not excreted in the urine. What is this form of bilirubin called? This is called unconjugated bilirubin. Okay. This is the unconjugated bilirubin. So what will happen? This unconjugated bilirubin will go into the liver, and there are hepatocytes here. Okay, so there is a special feature about the hepatocytes. We'll discuss it first, that the hepatocytes have two phases, the front phase and the back phase. Okay. The front phase is known as sinusoidal phase. This front phase is known as sinusoidal phase, and it will face the blood vessels or the capillaries. And this back phase is known as canalicular phase. It will face the biliary system here. It will face the drainage system here. Okay. So this bilirubin, this unconjugated bilirubin, which is brought to the liver, will enter through the sinusoidal phase of the hepatocytes, which is facing the blood capillaries. And what happens here? That there is a special protein on the sinusoidal phase of the hepatocyte. This protein will take the unconjugated bilirubin inside the hepatocytes. Okay, these are the hepatocytes. So this is the sinusoidal phase. This is the which is facing the blood capillaries. This is the canalicular phase, which is facing the biliary system. Okay. So there are special proteins present on the sinusoidal phase, which will take up the unconjugated bilirubin, right? Unconjugated bilirubin inside the hepatocyte. Now, inside the hepatocyte, we have endoplasmic reticulum. Inside the hepatocyte, we have the endoplasmic reticulum. What will happen here? Inside the endoplasmic reticulum, we have enzyme. We have one enzyme which is called glucuronide transferase. Glucuronide transferase. This glucuronide transferase will convert the unconjugated bilirubin to the conjugated bilirubin. How? That this glucuronide transferase will fuse the glucuronic acid with unconjugated bilirubin. So it will convert into conjugated bilirubin. Yeah. Now this conjugated bilirubin is highly polar and it is a charged compound. So as it is polar and charged compound, it will become water soluble, right? So this can be easily washed from our or pushed out from our body. So whenever the toxic compound is to be eliminated from the body, it is brought in the liver. In the liver there are hepatocytes that will convert them into the water soluble polar charge compounds. From it will get eliminated. Like for example, there is a glucose. The glucose gets converted into gluconic acid. This gluconic acid will convert into glucanic acid, and this glucanic acid will convert into glucuronic acid. This glucuronic acid will bind to the unconjugated bilirubin and will convert into conjugated bilirubin, which is water soluble, which is highly water soluble. Okay. Now, in newborns, what happens is, as discussed, that this bilirubin bound with protein is having larger size, so it cannot diffuse through the membrane and it won't damage the tissues. But in newborns, what happens is the blood brain barrier is poorly developed. The blood-brain barrier, which is a tight junction, is poorly developed. So this unconjugated bilirubin can easily cross the blood-brain barrier, and it will damage the cortex and the basal ganglia, and it will lead to connectors. It is mainly present in a newborn. Okay. So in this connectors, normally the phototherapy is given. Phototherapy is given, and secondly, the new therapy which is included is tin protofirin. Tin protofirin. The tin protofirin is a competitive inhibitor of the heme oxygenase. Of the heme oxygenase. This. So what happens? It won't. It this as this heme oxygenase get inhibited, it won't get the heme won't get converted into biliverdin, and the biliverdin won't be converted into bilirubin, and it will reduce the bilirubin. Okay. Okay, and this is also for the information purpose that there are certain drugs that will block or displace the binding of the bilirubin with this special protein. And what it will do? It will the bilirubin will be increased in the circulation. Which are those drugs that will displace the bilirubin? These drugs are sulfonamides. Sulfonamides. So the sulfonamides, which are mainly used in a newborn for the treatment of meningitis, should be used with caution. Why? Because it displaces the bilirubin from this protein and increases the free bilirubin levels, and it may cross the blood-brain barrier and can cause the connectors, increases the risk of connectors. The other such drug is a of penicillin. Okay. And in adults, there is one more drug that will inhibit the uptake of the unconjugated bilirubin into the hepatocytes. Which is that drug? That is rifampicin, which is mainly an antitubercular drug. So what it will do? It will inhibit the uptake of the unconjugated bilirubin into the hepatocyte. So the unconjugated bilirubin concentration will increase in a circulation. So, however, with the glucuronide transferase, the unconjugated bilirubin gets converted into conjugated bilirubin inside the hepatocyte. Hepatocytes have two phases. The one which faces the capillaries is known as sinusoidal phase. One which faces the biliary system. Biliary system is known as the canalicular phase. And once this conjugated protein, which is more polar, is formed, what will happen? There is one special active transporter here, which is known as MRP2 protein. It is an active transporter. Through this, the conjugated bilirubin will be expelled out of the hepatocyte and will come into the biliary system or the drainage system. Yeah. It will keep flowing here. It will flow here. This conjugated bilirubin will flow here. And here it is gallbladder. In the gallbladder we have bile. As discussed, that the bile is composed of mainly three components. That is the bile salts and acids, the bilirubin and the cholesterol. So this will travel along this circulation. It will reach the GIT, and inside the GIT there are bacteria and proteins present that will convert this conjugated bilirubin urobilinogen urobilinogen. Okay. This urobilinogen is further converted into stercobilinogen. Stercobilinogen. Okay. This stercobilinogen is responsible to impart color to a feces. Okay. And it is excreted out of the body. And while this urobilinogen is converted into stercobilinogen, certain amount of a urobilinogen is reabsorbed back by a GIT. A GIT and it will go into the hepatocytes again through the, here it is facing the portal vein, here it is facing the portal circulation. So which side it is? It is sinusoidal side. And here it is facing the biliary system. So this is the canalicular side. So certain amount of bilirubinogen will travel here, it will be reabsorbed by the hepatocyte, and here it will get recycled. Here it will get recycled, and very small proportion of the urobilinogen, very small proportions of the urobilinogen will come into the circulation. And since it is not a protein bound bilirubin, so it can be filtered through the nephrons. It can be filtered through the nephrons, and it will be present. It will be a component of the urine, urobilinogen. It will be a component of the protein. So this is the normal mechanism. Now, what will happen in jaundice? Okay, in jaundice. What is jaundice? Jaundice is hyperbilirubinemia. How this hyperbilirubinemia will form? How this hyperbilirubinemia may occur? So there are many mechanisms. So first is that the bilirubin production is increased. Bilirubin production is increased here in the spleen. How the bilirubin production will be increased? Through the breakdown of RBC, through the hemolysis, right? Other causes that it can, when the hemolysis is exceeded, when the hemolysis is exceeded, right? Or in the conditions of infection, the breakdown of RBC exceeds, it is hemolysis, or in a starvation, or when the patient is anemic. Breakdown of RBC, or when the patient is in stressful condition, the breakdown of RBC increases, that leads to the increased production of bilirubin in the macrophages. So this is one condition. Okay, and the second condition is that the production is normal. Production is normal, but the uptake of the bilirubin is reduced. This uptake of the bilirubin is reduced. As a result, the amount of unconjugated bilirubin in the circulation will increase, and will lead to hyperbilirubinemia, and will lead to jaundice. Here, the uptake into the hepatocytes is reduced. Okay. Then, what we have, the third mechanism is when we have the poor conjugation. That is, poor conjugation means the unconjugated bilirubin is not able to convert into the conjugated bilirubin, resulting in the elevated level of the unconjugated bilirubin. Okay, this mainly happens in the viral hepatitis when the hepatocytes are inflamed or infected. What it will do, that the glucuronide transferase activity is reduced, leading to the impaired conversion of the unconjugated bilirubin to conjugated bilirubin, and the unconjugated bilirubin will spill out into the circulation, and it will increase in concentration. And the fourth mechanism is when this special transporter MRP2 protein, okay, MRP2 protein is defective. There is a problem with the active transporter, which is the MRP2 protein. It is mainly a genetic condition, which is known as Dubin Johnson syndrome. So in Dubin Johnson syndrome, what happens is this MRP2 protein cannot transport this conjugated protein into the biliary system, and this conjugated bilirubin will increase in concentration here, and again it will spill out into the circulation and increase in concentration. The fifth mechanism is that when there is a intrahepatic or extrahepatic obstruction. Obstruction to bile flow, which is also known as cholestasis, as discussed earlier. How this happens, that when the intrahepatic or the extrahepatic obstruction to the bile flow, it will lead to the hyperbilirubinemia. It may be due to stones or infection. Okay. The sixth mechanism is it occurs due to genetic defects. What are these genetic defects? First is Gilbert syndrome. What happens in Gilbert syndrome? And in Gilbert syndrome, the glucuronide transferase or the GT enzyme, that is glucuronide transferase activity, is reduced, leading to the impaired conversion of unconjugated bilirubin to the conjugated bilirubin. Okay, and the second is the Klagler-Nager syndrome. In this, the GT activity is completely impaired. In the Gilbert syndrome, it is low, but in the Klagler-Nager syndrome, it is completely impaired. That leads to the increased concentration of unconjugated bilirubin. It goes into brain and it can lead to cardiac arrest in newborns. Yes, it is a genetic and this is fatal. Klagler-Nager syndrome is fatal. Okay, so these are the mechanism by which the hyperbilirubinemia is presented that leads to the occurrence of jaundice. Okay, now what happens in the symptoms of jaundice? So there is a yellow discolorations of the sclera. Yeah, as you can see that there is a prominent yellow discolorations of the sclera. Okay, the sclera becomes yellow in color. There is a yellow discoloration of skin, mucous membrane, and interstitial fluid. There is a reduced appetite. The patient will have the reduced appetite. As there is a reduced appetite, the patient will have the weight loss. Okay. In some patients, itching may develop, right? And the patient may have the fatigue due to the weight loss and reduced appetite. The patient may complain of the nausea and the vomiting. Patient may have the constipation, abdominal heaviness, or abdominal pain. And as it is a hyperbilirubinemia, more amount of bilirubin will be excreted in the urine. So the urine will become dark yellow in color. Okay. Patient will have reduced appetite, discolorations of skin, scala, mucous membrane, interstitial fluid. Some patient may develop itching, fatigue, nausea, vomiting, constipation, weight loss, abdominal pain, and dark color of urine. Now, how will we diagnose this jaundice? So first we have the CBC. In the CBC, we can rule out the anemia, hemolysis of RBC. Then we can check the ALT, that is a liver function test, ALT, AST levels. That will rule out the amount of hepatocellular damage. Then we can check the total bilirubin level. We can check the total bilirubin level. In the total bilirubin level, we have two. that is unconjugated, as discussed, unconjugated, and we have conjugated. So the mechanism discussed here, the first one, two, and three mechanism will lead to increase in the unconjugated bilirubin, and in the fourth and fifth will lead to the increased concentration of conjugated bilirubin. So we can have the bilirubin test done. If it's elevated, then it's, and along with the physical examination, we can go for conclude that's jaundice. Then we can have the gamma glutamine transferase test for the biliary obstruction. That if there is an intrahepatic or the extrahepatic obstruction due to any stone. Also, it can be ruled out with the imagining test with the USG. Okay, we can rule out any obstruction. Also, to rule out any obstruction, we have the urine test. Why urine test? That, as discussed in the urine, the urobilinogen is excreted. If in the urine this urobilinogen is not present, that means it is not present in the circulation. If it's not present in the circulation, that means it is not being absorbed here. If it is not being absorbed here, that there is a problem between here in this section till this section. There is a problem here if we don't detect the urobilinogen in the urine. Okay. Then the last we have the liver biopsy, and we have the prothrombin time and the amount of albumin. So that indicate the liver decomposition and the synthetic function of the liver. And then we come to the treatment. Mainly, the treatment of the jaundice is done on a basis of cause. So if there is any obstruction, then we can go for the surgical removal of the stones. And as the patient complains, sometimes complains of itching, then we can go for the antihistamine, that is levocetirizine 5 mg. We can also go for cholesteramine for reducing the itching, that is 2 to 8 mg twice daily. Patient complains of nausea and vomiting, so we can go with the injection MSET 4 mg or ondansetron 4 mg tablet. Okay. Then the patient may have the weakness, so we can go with the multivitamins, we can go with the fluid management. Okay. Then we can also go with the tablet ursodeoxycholic acid. And also lactulose is used for the constipation. Lactulose is mainly available as 30 ml syrup. So mainly it is given 5 ml twice daily. Then we can go with antibiotics. Okay, these are antibiotics. Injection penicillin 1.2 gram twice daily. We can go with ceftriaxone sodium, ceftriaxone sodium twice daily. We'll go with the injection Pibso. Now, this is used when the bilirubin level in a body is extremely high. Okay, so this is used when the bilirubin level is extremely high in a body. So it is very very effective therapy, that injection Pibso. Pibso is composed of piperacillin and tazobactam. It is given 4.5 grams infusion IV twice daily with a Dexona, which is a corticosteroid, to relieve the to get the complete and the immediate relief with the symptoms. So this is all about jaundice. Thank you.